This is the fourth lecture of the series, The Pelvis and Perineum. Here, I will present the male and female perineum. My name is Carlos Andres Suarez-Quian. I am the author and narrator of this lecture. As before, I show you the objectives that I will use as subject headings for the slides. Previously, we discussed the area of the pelvis, the area in red. Now, we move a bit inferiorly and cover the area of the perineum, the area shown in orange. It is just below the pelvic floor. And let's look at the perineum from below. This is the view that a clinician would see if the patient were to be in the lithotomy position. That is, the patient's on their back and their legs are on stirrups. The clinician is about to perform a pelvic exam. Let's define the perineum, a diamond-shaped space just below the pelvis and between the thighs. The diamond-shaped space extends from the inferior part of the pubic symphysis laterally to the ischial tuberosities on what you're sitting on right now. Posterolaterally, the boundaries are made by the sacrotuberous ligaments. And posteriorly, the perineum is bounded by the tip of the coccyx. If we were to draw an imaginary line between the two ischial tuberosities, we would create two triangles. Anteriorly is the urogenital triangle, and posteriorly is the anal triangle. If we look at a sagittal section of a female pelvic dissection, shown on the left, and a drawing of a similar section shown on the right, we can now discern the superior and inferior boundaries of the perineum. The floor is the skin, the roof is basically the pelvic floor, the levator ani muscle. And the same holds true for the male perineum as well. And within the space just defined, there are actually two distinct pouches, the deep and superficial pouches. The deep pouch is also the urogenital diaphragm. Its superior border is formed by a loose connective tissue layer just inferior to the pelvic diaphragm. The inferior border is a perineal membrane, a thick sheet of connective tissue. We will say more about the pelvic diaphragm later. Let's explore now the anal triangle and its contents. We examined this area previously when we studied the muscles of the pelvic floor, and what we're looking at is a dissection of the ischioanal fossa on the left and a drawing of the similar area on the right. Remember its boundaries and associated structures? Midline structure is the anus in both the male and female. This is a male dissection. The lateral wall of the ischioanal fossa is the obturator internus, and its medial wall is the levator ani that takes its origin from the deep pelvic fascia of the obturator internus. The content of the fossa is mostly fat. We now look at a sagittal section of the anus and associated structures. Although this is a male, similar structures are present in the female anus. Recall what we discussed in the previous section. The anus is of a different embryonic origin than the rectum, and consequently receives distinct arterial supply and venous return that is of clinical relevance. Review the differences between a painful versus a painless hemorrhoid with respect to what it means for the venous return of the two areas. The lymphatic drainage of the anus merits specific mention, again because it can be explained in terms of the blood supply. Lymph fluid from tissue located below the pectinate line, indicated by the thick green line, drains to the superficial inguinal lymph nodes. Above the pectin, lymph will flow towards the iliac nodes. The reason this is important to note is that a lump in the groin may be a clinical sign that there's an infection in the ischioanal fossa, not an uncommon occurrence, perhaps due to a fistula existing on the anal walls. The anal contents are not sterile, and the presence of a fistula at this site is often associated with painful abscesses in the fossa. Hence, the lump in the groin is readily explained because it is to the superficial inguinal lymph nodes that the drainage of the anal canal occurs. Looking at the dissection on the left and the drawing on the right, one can see that muscles are present surrounding the anus. I am sure that you have figured out already that these muscles are indeed under voluntary control. In times of need, you can constrict these muscles. These muscles are called the external and internal anal sphincters and work by constricting the opening of the anus. There are distinct differences in the innervation of the two muscles, however. It is the external anal sphincter that is under voluntary control, whereas the internal sphincter is made up of smooth muscle and thus regulated by the autonomic nerves that we discussed previously. Parasympathetic nerves will help with bowel movements by activating the internal sphincters, leading to contraction and relaxation of bowel muscles of defecation. Visceral afferents, in the form of stretch receptors in the wall of the rectum, will be sympathetic. Somatic pain from the anus will be carried by somatic afferents, given that this tissue is akin to skin. We now move to examine the structures found in the urogenital triangle, first in the male, and these include the external reproductive organs. On the left is the penis and scrotum of a cadaver. In the middle is the penis after removing the skin, and on the right is a drawing illustrating the muscles of a urogenital triangle. Removal of the skin reveals three muscles of the superficial pouch. These muscles are the superficial transverse perineal, the ischiocavernosus, and the bulbospongiosus. The bulbospongiosus and the superficial transverse perineal join up in the midline in an area known as the perineal body. This area is central in maintaining the integrity of the urogenital triangle, but in the male, it is generally of little clinical significance because the muscles are rarely injured. In general, these muscles help support the pelvic viscera, help maintain erection, and help to expel urine and semen. They are all innervated by the pudendal nerve. We will discuss this nerve in more detail in just a second. Removal of the muscles exposes the erectile tissue of the penis. These include the bulb of the penis at its base that gives rise to the corpus spongiosum. On each side of the base of the penis is a crus. The two crura then extend as the corpora cavernosum, which is plural of corpus cavernosum. And distally, the corpus spongiosum expands to become the glans penis. All the structures we have been discussing so far are found within the superficial pouch of a urogenital triangle. The upper boundary of the superficial pouch is a thick connective tissue layer called the perineal membrane that stretches from one pubic ramus to the other. The arrangement of the three erectile tissues can be observed in a cross-section of the penile shaft. Note the two corpora cavernosa on the dorsum of the penis and the single corpus spongiosum on the ventral aspect. The body of the penis is suspended from the pubic symphysis by the fundiform ligament, and note that the male urethra is only present in the corpus spongiosum. The penile urethra then continues past the perineal membrane to enter the deep perineal pouch. The urethra within the deep pouch is known as a membranous urethra and is surrounded by the deep transverse perineal muscle. This muscle is under voluntary control. In addition, Within this deep pouch are two pea-sized bulbourethral glands, also called Cowper's glands, that secrete mucus into the urethra prior to the ejaculate. The membranous urethra then becomes a prostatic urethra and eventually enters the bladder. In males, there's an internal bladder sphincter that is under autonomic nerve control. One of its functions is to prevent retrograde ejaculation. We now move to the female urogenital triangle and first examine the vulva that represents the external female reproductive and urinary organs. Vulva is derived from the Latin term for wrapper or wrapping tissue. The components of the vulva that are readily visible include the mons pubis, clitoris, urethra, labia majora and minora, and the vagina. The vestibule is considered the cleft between the labia minora. Removing the skin of the vulva, we see in the female the same three muscles described in the male in the urogenital triangle. These are the superficial transverse perineal, the bulbospongiosus, and the ischial cavernosus. Here, however, unlike in the male, the perineal body is of significant clinical relevance. The perineal body is sometimes cut in a procedure called an episiotomy, either as a midline or a mediolateral incision. This surgical cut is made at the opening of the vagina during childbirth to aid a difficult delivery and prevent rupture of tissues. Complications of the procedure can include extended healing time and future problems with incontinence due to damage of the perineal body. Serious complications due to damage may also result in prolapse of the uterus and/or the bladder. Continuing on, as with the male, removal of the muscles exposes the erectile tissue in the female vulva. These are named exactly as in the male. The bulb of the vestibule, however, does not extend to the clitoris, or only as a vestigial ligament. Glands that open in the vagina are located in the superficial pouch. These are the vestibular glands, or Bartholin glands. Their function is to secrete lubrication into the vagina. They can become infected and/or cysts can develop in them, and it is an extremely painful condition for the patient. The vestibule of the vagina opens up into the vagina proper, and the cervix of the uterus enters its posterior wall. The posterior walls of the vagina form arches around the cervix, and these are called the anterior, posterior, and lateral fornices. Fornix is Latin for arch. The posterior fornix is by far the largest of these and can be examined using a speculum, as shown in the slide. And do you recall the important relationship of the posterior fornix to the pouch of Douglas? Females also exhibit a deep pouch in the urogenital triangle, and it too contains a muscle, the deep transverse perineal muscle. This is a voluntary muscle. Unlike in the male, the females do not express an internal urinary sphincter. The relative short urethra in the female is one possible reason for why females have a greater frequency of urinary tract infections than males. The last topic to discuss is the plumbing of the perineal region, that is, the nerves, artery, veins, and lymphatics that serve the structures present in the anal and urogenital triangles. First, the nerve that we're talking about here that serves the perineum is called the pudendal nerve. The artery is called the internal pudendal artery, and the vein is the internal pudendal vein. In fact, we're talking about a neurovascular bundle of nerve, artery, and vein. Let's focus on the nerve, but understand that the internal pudendal artery and vein travel along as well. The lymph drainage is basically the same as the arterial system, but in a retrograde fashion. The pudendal nerve is a branch of S2, S3, and S4 that exits the greater sciatic foramen and then re-enters the pelvis via the lesser sciatic foramen. Remember back in the first section of this lecture series when I mentioned the nerve that made life worth living? This is the nerve that individuals refer to. After re-entering the pelvis, the nerve gets off the inferior rectal nerve in the ischioanal fossa. This is the nerve that serves the somatosensory and somatomotor function to the external anal sphincter. The nerve then enters the pudendal canal. Understand that this canal is found within the lateral wall of the ischioanal fossa, the wall formed by the fascia of the internal obturator muscle. Next, the nerve sends branches by way of the perineal nerve to serve the scrotal region. And finally, it becomes the dorsal nerve of the penis. Lateral arcading branches from the dorsal nerve of the penis provide a sensory pathway for the ventral and lateral penile shaft, and the termination of the fibers at the corpus spongiosum is consistent with the pudendal innervation of the penile urethra. Penile tumescence is not dependent simply on normal nerve stimulus, however, but requires a functioning hemodynamic mechanism as well. Trauma to the pudendal canal would compromise the blood supply to the penis and block penile tumescence. Indeed, enhancing blood flow to the penis is the basis of the medication known as Viagra. Finally, we reach the dorsum of the penis and note that the dorsal nerve of the penis, the terminal branch of the pudendal nerve, is lateral to the terminal branch of the internal pudendal artery. Further, there's only a single prominent deep dorsal vein of the penis that drains back to the prostatic plexus. The path of the pudendal nerve in the female is identical to that of the male. In no way am I trying to diminish its importance in this presentation by not showing its complete path from where it starts to its termination as a dorsal nerve of the clitoris. In reality, the nerve is much more difficult to demonstrate in a cadaveric dissection, and that is the reason why anatomists have a difficult time demonstrating it. What is of clinical relevance regarding the nerve, however, is understanding how it can be anesthetized by using anesthetic near the ischial spine, precisely where the nerve curves around the ischial spine to re-enter the pelvis and proceed into the pudendal canal. This is the anatomical basis for performing a pudendal nerve block during parturition to eliminate pain from the perineal region in a mother giving birth. And you may have wondered what pudendal means. Indeed, you may have attended an artist's lecture and heard them describe the pudenda when discussing a nude. It means shameful. Yes, shameful. Our external reproductive organs are described by anatomists as the shameful organs. The reason for this dastardly description goes back to this individual, Realdo Colombo, who followed the great master Vesalius as anatomy professor at Padua. The story goes that Colombo dissected the female perineum and recognized that the female clitoris has but one function, sexual pleasure. Some would argue this has been known prior to the study by anatomists, but I will not argue that point here. Anyways, the church at the time could not believe that the female body had one organ simply devoted to sexual gratification, and prohibited Colombo from publishing his findings. He would have been described as a heretic had he done so, and likely burned at the stake. He did not publish his findings, and instead came up with the name of pudendal nerve, the shameful nerve, to appease his inquisitors. The great irony for us here at Georgetown, in the realm that is a small world, In the same book where Colombo had described his findings on the clitoris, he also had figured out how the heart-lung circulation worked. Because he did not publish, William Harvey took the credit nearly 100 years later. Our own Proctor Harvey, I was told, is a direct descendant from this Harvey. This now concludes the lecture series on the pelvis and perineum. I wish to thank Mr. Mark Savonia, who prepared all the cadavers used in this presentation, and the anatomical donors for their generous gift. This work could not have been done without them.